Welcome, everyone. I'd like to call the meeting to order. The first item on the agenda is approval of the agenda and the previous minutes. Has everyone had a chance to review those? They're from March 28th, way back in March.
You'd like a motion?
That would be great.
So moved.
Second.
We have a motion and a second. All in favor say aye. Aye.
Aye.
All right. It says report to the chair. I don't have anything to report this time. Report to the CEO. Call on Brian Ingram.
I didn't know where to start.
Well, we're here to listen.
Yeah. I was in Raleigh yesterday. We had our meeting with the department, and we got some news this morning. Let me kind of go in reverse order here. All of these things will fit together at some point. And I guess this would come under the topic of how unusual and I guess somewhat unpredictable our budget is going to be for some period of time. So all these things are related in one way or another. And I guess we just kind of go back to, when we put the budget out, how we emphasize it's sort of a, best effort at this point in time. It's going to be like that for a while. So just this morning, we learned that the House has this, they're calling it an omnibus health bill, or it's going to be in some PCS or something, but there's some vehicle that's being used to put a collection of legislative items in, one of which, Christine, is the, that IVC bill is getting pushed back. A deadline probably a year. Or on that. And then,
What's obviously?
Voluntary commitment.
yeah, it's this whole big piece of legislation from last year that requires counties to develop transportation plans. You remember we talked about it?
We've been working on our side, I know.
Yeah.
You may get more time.
Yeah, that sounds like it, yeah. Well, that's, I guess that's good news.
Yes. There was no way this was gonna get
No.
done in time. I think it was October 31st or something was the
October
original
1st.
deadline for things. But really the big thing is the department's agreement to push back the implementation of standard plans until March of next year.
That's what we're hearing.
Right. Now, this is what we're hearing.
So they'll start like with zone 1 in March instead of November?
Correct.
Interesting.
Now,
With,
The Senate has not signed
yeah,
off
let's
on
do a
this.
timeout, right. This is a House bill at this point, and from the tenor of the conversation yesterday with the Secretary and others, I wouldn't say that this comes as a surprise, but since the Senate would have to agree to that, and they'd have to get this done, the House was planning on leaving next week, I believe. I mean, this is going to have to happen very, very quickly. And again, it's hard. So we've got that piece, okay, that we'll wait to see how that pans out. So how does that affect us? Well, that changes the period of time for which we have rates that are done a certain way because we're losing population, okay? So we have this limited rate offer that we have agreed to under protest, and we'll talk more about that later. That would have been until November. Well, that would then change because the plans wouldn't be going live in November. So that's a change in our budget that we can't, predict at this point, but we'll need to really stay close to that. And I talked to Rick Zucchini this morning about it, so he's all over that. The stay that some of the plans had requested based on essentially them disagreeing with not being selected to be standard plan contractors. It was in the middle of a meeting with the secretary. We got a text message saying that that had been denied. So that's another one that would have moved the needle on everything. Now, whether that was good news or bad news was kind of like, you know, a wink and a nod about that, because the department, I'll say with all due respect, has really been struggling. Really been struggling. And the rumor, I guess, and probably more than a rumor, but the information about their agreement to go later today, it does not come as a surprise. They're, of course, without a state budget, you know, and there is the compromised budget has come out. You know, there was the House budget, and then the Senate budget, and then the compromised budget. That came out, I think, like Wednesday morning or something like that. You know, everybody expects that that will be vetoed by the governor.
I would think so.
Yeah.
Strongly, so then they come back.
Had a conversation, you know, last night,
Yeah.
counting noses, and, you know, they have some Democrats who have slid over, but they don't have enough. So that's another feature that makes our ability to create a budget just, you know, unknown. We don't have a state budget. We're predicting that we won't because the governor would veto. They'd have to go back at it. What would happen? I mean, you know, we could spend the rest of the day talking about what might happen and how that would affect us.
You said
That's ugly.
some Democrats slid over, but not enough. Is that to override?
Correct.
Yeah.
They're, what I was told last night, I think they're 3 or 4 short. So, and again, if we start at this high level, you know, the big piece of business we have to do today is get a budget passed. We'll do that, but don't get too attached to it.
Yeah.
Don't get too attached to it. Because just in what I told you, you know, 1 to 2, you know, 3 things that are going to change it in ways that we can't, you know, we just have to wait and see. I will say in particular, there was a recalculation of the single stream reduction that had a very, very negative impact on us. We could talk more about that later. We had the second largest reduction, and all of these reductions now are, and you know, I always kind of joke about this, and I think we all deserve to joke about it, recurring versus non-recurring, and how that has just turned into whatever anybody wants it to be. These are all recurring cuts. And ours was moved up to $9 million, second only to Cardinal. And we'll talk a lot about this later. And again, this is in the budget that the governor is going to veto. So a lot of work we're going to have to do around that. And that started the minute that I got a photograph of the page in the budget. Okay, so we're on it. So at a high level, you know, you guys asked me how I was doing. That's just yesterday. That's like this week's stuff that we're.
So was that the good news report?
That's just the news report. The news report. Whether it's good or bad remains to be seen. How's that?
Good answer.
You know, we're wrestling with some big, big things. And I'm trying to think other than that, some of the highlights. It'd be interesting to see the kind of support we get. I was joking with, Tracy and Clark, this morning. We were kind of getting our wits together and organizing some material. Remember when the Saints, who were they playing in the playoffs? That they had that famous no call?
Rams.
The Rams? Everybody remember that?
Oh, yeah, I remember. Christina remembers it too.
Now you remember? I was
That's-
carefully explaining this to Tracy this morning.
I vaguely remember it. My sons remember it.
That's when it was pass interference deluxe, and they didn't call it.
Yeah,
Right
the
in front of
defensive,
referee.
the defensive back acknowledged that he was making a
He
desperation
went temporarily blunt.
play, to save a touchdown, take the penalty, which would have put the ball on the, the 10-yard line or whatever, but he did it to save a touchdown, just intentionally creamed the guy. I mean, and he said, yeah, of course it was pass interference. Well, everybody in the world thought it was pass interference except for the referee who was standing, like right over there. Okay, so that's about how this $9 million cut is for us. Everybody's saying, that's ridiculous, something's wrong. Now what is anybody going to do about it? So,
Who's the referee?
I want the replay.
Who's the referee in that?
I'll tell you
Some
what,
committee?
who is the referee? It's the
Ralph.
governor, the House, and the Senate.
Yeah, I understand that. I thought maybe there was more specific referee.
Well, there always are
Yeah.
specifics.
I figured there probably was. I've refereed basketball for 20 years, so I've
Appreciate it.
made some bad calls.
Gary can't drop you out Center County.
They love me in Alexander. Now, that's true.
That's what they want you to do.
Yeah, they do. They love me over there.
They're the ones that pay you off, right?
Oh, yeah. They have good food. The Booster Club has good food.
So, any one of these topics we could talk a lot about. These are obviously very, very, very big things for the entire state. And some in particular, of special impact for us, that single stream fiasco. And we'll be prepared to speak more at length about those later, I guess would probably be the best way to put it, with more detailed information. But be happy to answer any questions or talk more about things. It seems like sort of a good place to draw it here.
Mike, you and Gary,
Ronnie said he'd be at 4:30.
Okay.
For what that's worth.
Thank you.
Yeah, I can tell you, I went to a provider meeting, was that last week?
Last Wednesday, you were there, yeah.
Yeah, last Wednesday, and I really try to go to all of them when I'm here and just talk and answer any questions they had. But I did talk about the budget, and even though we didn't have the final budget, I could already see, because of the very, let's say, privileged conversations I was having, where things were going. And I told them that we were going to be having cuts to providers, without a doubt, and we are. And then had a smaller meeting with what we call our comprehensive providers, which is we had all the CEOs there, didn't we?
We did.
From Appalachian, Meridian,
County Prez, RHA, and Daymar.
yeah, the CEOs of all of those agencies, and just said, look, help us do this the best way we can. What are the nobody wants to do this, but this is what we have to do. This is because of the single stream reductions that every year in the past we've covered with fund balance. We're not doing that this time. We've gone down low enough, so we're passing the cuts along. Now, one of the provisions in the budget, for the first time, lets us do that. Because the requirement, I guess there's two key pieces. There's the amount per se, which the House took 36, which was the recurring portion from last year. The Senate added 7.5 to that, so we're at 43 or 44 and change statewide. Our portion of that is like 20% or 9 million. We took half of the cut that the Senate made of 7.5 million because of the methodology that they used to calculate the reduction, which is a lot of things wrong with it. But anyway, the good part about that is they did leave the allowance for, call it the rebate. Essentially, if the Medicaid budget has a surplus, there's a $30 million statewide rebate that is prorated that comes back to us. And the one different thing this year is that, as opposed to the past where we had to keep funding flat, we had to keep services flat to the 14-15 level, which is kind of the base year when they started making all of these reductions. They said now you only have to meet 90% of that.
That was going to be my question. So heretofore, it's been
Correct.
maintain the service level, less money, figure it out.
Right, yeah, which is pretty simple. Use your fund balance.
Yeah.
Mhm. So this year, we only have to, the requirement is only that we fund, that we have services at that 90% level. So we will be exercising that option. At whatever point we get a budget, that'll be in there. I've already told the providers, we're going to be doing that. This is on the order of, $5 million or so. Let's use that for planning purposes. And in fact, today, we asked them to submit their recommendations for how we can make the cuts.
And those will be strategic as opposed to
Very
more-
strategic.
Yeah.
There's just a lot of factors to consider with how we do that, not the least of which is to prevent us from getting any penalties around super measures, different performance areas that we are liable for penalties. And then, maybe, it'd be the biggest factor of all, and you guys all know this from doing your budgets, are we going to have 12 months to make that reduction, or we don't get a budget until September? Well, what does that mean? We lost July, August, now we've got 9 months to make up for cuts that were designed to be for 12 months. Well, what does that do? Well, that makes them bigger, right? Because you got to make up those 3 months. So the later the budget goes, the harder it is to manage the reductions. You with me? So we just talked all of that out. And, there are no, is there some like silver bullet, pull the rabbit out of your head? We did that last year. Using, again, it's going to be a little too hard to probably explain in detail, but an alternative service definition called an in lieu of ICF care, which allowed us to take a lot of IDD folks who have Medicaid, okay, but we're getting a lot of state-funded services because they're on the waiting list. So they qualify for intermediate care facility level of care because the waiver's full, there's no slots left, So they're out here getting some amount of services to do the best they can while they're waiting, getting a lot of state-funded services. Well, we got this new, different Medicaid service where we were able to provide a lot of those services that were funded by state dollars by Medicaid. And because they were individuals already eligible, already Medicaid recipients, we could use Medicaid to fund their services, which in the past has always been, excuse me, a good shell game for us, because there's a lot more money on the Medicaid side. Well, we're losing money on the Medicaid side this year too. So it's not exactly, it's better, it isn't great. And look, I've told you, everybody's losing money. That's the one context for this is, as we, maybe get discouraged by some of this, everybody's in the same boat. Everybody's in the same boat. So, the question about whether or not this is a strategy to do this to the LME MCOs, I'll let you decide it. How valid that is as an approach that's being used.
I would be curious, from a commissioner's standpoint, to know what the anticipated impact is going to be on the county that I'm in, that I'm on the board of. And the numbers, and then what do those numbers translate into in terms of reduced services and like the demographics and everything of who those folks are, and then we could begin to have a discussion about, well, how do we make up for that difference? And so, like you said, the longer you wait, the tougher it is to make it up as well. So I'm curious about that. And then also I could see a role for the association in advocating that those cuts not be as dramatic as they are. Rick, do you yeah,
Absolutely, yes.
because it's going to hurt everybody. It's going to have a dramatic effect on a lot of our social programs, I know.
Well,
So-
we can cut to the chase for Wilkes.
Yeah.
We said that we would be on the hook for what, $260?
268.
So we're gonna send $268,000 your way while we're closing down other things. What's gonna be the optics of that? And what words is anybody, and I would have to say to you, and not to start the world on fire, I don't know what we can do and can't do. We got these numbers now. We don't know what they're gonna be ultimately, but this is a game changer, complete game changer. So, we're gonna have to be all together on this. We will make whatever recommendations we can. And then, all the board has to really understand this. Whatever county commissioner meetings, don't shoot the messenger. This is exactly what we've been telling people. Exactly what we've been saying. All of the reports that Clark makes to the county finance folks. Exactly what we've been saying, okay? There's nothing surprising about this. People haven't paid attention to it. What's different is we always buffered this in years past, and we've been saying we're not going to be able to keep doing that. And we're right, and this is the year where we're not going to be able to do that. So no one should be surprised. And whatever the cuts are, they're going to really be felt. These aren't going to be like soft things here and there. From sitting with the providers going over this, it's, I don't know, Christina, you were in that same meeting I was.
Yeah, I think that we're really talking about, as Brian's talking about the seriousness of all this. The CEOs have all agreed, either them or their designated person will submit their recommendations on either what they can eat, what they can absorb, or what just would have to be cut, and some of that. We've had several calls this week from a couple of those CEOs myself. I've had people call me and just say, this is not going to look pretty on paper. And I think that because, we know where we have been, and we have to always remember this population is the uninsured and underinsured group, which does not mean that Medicaid. And most of these people are adults that we're talking about in these communities. These are all your citizens that everybody is concerned about, and everybody wants something to be done. And so when you think about where your money's sitting, you think about your walk-in centers, you talk about your facility-based crisis, you talk about your behavioral health urgent care that we have here, and if we talk about other services in the adult way, the service called community support team or ACT team, assertive community treatment team. I mean, these are some of the most chronic people that, again, in the Taylor plan, we're responsible to serve, need to serve, and again, none of these people are being, so we have been able in years past to put money aside based on our fund balance to pick up some of those people who are uninsured and not on Medicaid. Had 2 conversations this week with some providers. So both of those services, community support team and ACT, assertive community treatment team, the way they're leveraging those, because those have psychiatrists, social workers, all kinds of people in those teams. They're serving people who live in the community. And the way they're leveraging those teams is a lot of them are Medicaid, but a lot of them are also on the state-funded side. So that the mixture of funding, when they're back in their offices trying to tease that out. So we would continue to do these services for the people we could get paid for, and then we would just have to close our rosters and then just let that treatment roll out. We've got people in treatment, you couldn't just abruptly stop it. So, the average length of that treatment is somewhere 3, 4, 5 months out on some of those teams. So the responsibility of that, knowing you may not get the money to do that. So, we're down in the ditch in some of these conversations. I've been on a lot of calls. High concern. I've seen emails among some of the providers really want to advocate for us. Really, and Brian did a great job explaining the campaign that's trying to go on. And we saw yesterday the chair of our Provider Advisory Council, Jeannie Duncan, sent out something again, had to talk to points, and I saw some other emails she sent that I was copied on. Get out there, talk to people. You have to understand what is happening to these communities and the impact. They saw the $9 million even before we said anything to them. Just the timing of that, and they were already, because a lot of them watch it just like we do. So, I think they're very concerned about the relationship with the counties. They're very concerned about the message to the consumer, who in the world is going to understand all this, and what it's going to take. You can imagine the sensitivity of cutting any amount of service for this group of people. And then you have this huge movement that we've been talking about for years about trying to get people not to be diverted to the ED. And where are people going to go if you cut out these kinds of services? They're going to go to the ED. And so it's just this huge, I can bring you on to all the ditch where I've been living this week in this conversation, but just the tentacles that this decision has. Just in your own communities, you think about where people would go and what they would do, and the face of this is not pretty whatsoever. And I think not only us, but our providers are very concerned with what it will look like.
There's another facet of this for the counties too, because I've been studying this for one of my clients, who's a county, and that is the Medicaid expansion in Department of Public Health is happening simultaneously with all this. And in some instances, they're just going to go back to the absolute basic things that they do and nothing else. If there's no frills, which they can't afford to do all the other stuff that the contracts are being imposed on them if they accept the contracts. So you can just, and the clients out there are not going to be able to distinguish the difference between what's going on in behavioral health and what's going on in public health. It's just a big mess as far as they're concerned. So I don't know if you've been talking to the Department of Public Health or not.
Well, I'm not on the health department board, but I will. But what Medicaid expansion are you talking about?
Across the state.
Yeah.
It's
like modified program, they're not calling it Medicaid expansion.
Departments of Public Health are being handed anywhere from 4 to 6 different contracts that have been presented to them by some of the same people that we're working with in behavioral health, Blue Cross Blue Shield,
Right, okay, I understand.
AmeriHealth, and some others, and they basically say, if you're going to participate in Medicaid expansion, you've got to do all of this stuff.
Well,
And they
Medicaid
can't afford
transformation.
Yes, you're talking about-
Yeah, transformation, yeah, they're not expansion.
Standard
Yeah,
plan
yeah,
of
yeah, we're
business.
talking, yeah, now I get you. Now, yeah, I understand that part of it.
Yeah, so they'll have to enter into these contracts, or they'll just say, we're not going to do that, we're just going to go fee for service, which means they'll have to go back to just really basic stuff.
But people's needs weren't getting met in all these situations. It's like, I think, as a community, that being inclusive to all of us, is what are we gonna do and what's gonna be our priority? And over time, we're gonna have to really understand that and just know. You know, I'm out here today, I was in Boone and we were doing our last Senate Bill 630 Community Crisis Planning, meeting, and I'm sitting in that room and thinking, this doesn't match anything at all in this conversation.
Yeah.
I mean, it doesn't. So, I'm not there to talk about that. Nobody brought that up. It wasn't really appropriate to talk about that this morning in Boone. But, it's like, here we go. I mean, because we cannot forget you talk to these providers, 60 to 80% of the people in the services that might have the potential to be cut are uninsured and underinsured, and they're adults chronically mentally ill and or substance use. And that's what they tell you relentlessly. Do you understand the population this is going to hurt the most? But that's what we're so scared about.
I've always said, there isn't a strong advocacy group in Raleigh for that group of individuals. They're just not getting their voice heard. So, the impact of this and the effect it has on the rest of the society
Correct.
is going to have to be the advocacy for it. So it's going to have to come around kind of full circle.
I did.
I think that's the element that's going to have to come into play through organizations like the commissioners and even the city, municipal.
I mean, I emailed, after we had our county commissioner advisory board meeting, I sent an email to Kevin Leonard saying, look, I want to talk to you to let you know.
Yeah.
And I don't think we've gotten anything back from him.
Yeah. He wears a lot of hats.
I know, I'm
He's
just
probably one
saying.
of the busiest people.
Yep.
But I think he's pretty tuned in to all this, though. I think he understands that.
What else?
So there's gonna be cuts in services. So folks are not gonna be cared for. But then come tailored plan time, whether that gets moved back or not, but come tailored plan time, those services have to come back.
Well, remember now, you gotta separate out the Medicaid world from the non-Medicaid world. Tailored plan is all about the Medicaid world.
And they're going to be fine, right? I mean, better, relatively speaking. I mean, they're going to be,
Define fine.
well, better than the indigents and the underinsured.
Yeah.
Right.
I think that's
Clearly,
fair to
yeah.
say. That's
Now,
fair to say.
I've begun to understand this over the past couple of years, that the dynamics of the money and the funding, and I've advocated for this idea of, hey, what are we doing to make sure that the indigents, and I know you were using money that was for other things and fund balance, and that those days are over.
You wanna get really scared?
Those days are
This
behind us.
the state's in great economic shape.
Oh,
Surplus.
700 million revenue, and so they're gonna cut everything. And what are they looking to do? And here's the way I look at it in the back of my mind. They're looking at, okay, the LME doesn't have any fund balance. Well, Wilkes County's got a 38% fund balance. We'll just pull this back and then we'll put it down on them, and all the impact's gonna be at the local level. So what are we gonna have to step up on an unfunded mandate and take up the slack?
What do you think it's gonna like when we have a recession again?
And then we get a recession. Yeah, well, all bets are off now, I guess.
This is the good old days.
Yeah.
Now, economically.
Oh, yeah. Well, it's pretty good.
So the services are gonna get cut. People who have been served are not gonna be served.
Correct.
And there's no service coming for them on the horizon.
Based on the budget that
Right.
the governor is likely to veto.
Well, in that context, that's what I'm asking
And
you.
we can, then the next conversation, of course, would be, what would anybody have a reasonable expectation to change in the next iteration of the budget? And that's what we gotta get really busy on.
Can I say a couple more things?
Please.
So, I think, Mike, what you're saying is that, yes, services will get cut. One of the things, and a part of this is to really challenge all of us and our providers. Things that are happening here, this conversation is happening in many other places. And, one of the things that we learned a lot as we moved to the tailored plan is that service models of care change. This isn't to justify that this is good, that this is happening. But what providers want to do is they want to provide medication, some type of outpatient, and some type to figure out how much crisis services can we keep in place. And what we've done, and what these providers have done, is really looked at models. We've even talked about some of these models even before this conversation within this building. We know that peer support and a nurse can do a tremendous amount of work, and in some places in this country have had better outcomes than the traditional models we've been doing. And so what we really tried to push the providers to do and ourselves to do, clinically, I was talking with Rhonda and Craig yesterday evening about some things, is just, if this is the problem we have, how do we know in these situations with this amount of money, or less money that we have, what have people done and how have people prioritized? So to really try to be smart in doing this. So whenever this organization with you and the board, understands these codes and we have to agree to whatever we agree to, then what are the models that we put in place and how can we use how can we leverage the money we have to serve as many people as possible and do what we really know that people really need, no more, no less. And I think that I would want the board to hear that because I think that's really, really important. You've got to go out there and say something. Is it the same of what we do today? Probably not. And it's a hard sell to say that, in Nebraska or Wisconsin or Vermont, wherever you look at these models, in rural areas, poor areas, chronic mental illness and substance abuse, how are people today serving people? And so there are models to look at. So I'm not trying to justify that it will be as good, because I don't know personally. All I know is I've been trying to talk to people at some of the national level, look into things, really pushing our providers to think about different models. And, Rhonda and Craig and I had a really good conversation. We talked about even in the tailored plan, this thing about having some peers, and again, these peers have to be way more trained and certified in other areas to be able to do some of this work that I'm kind of alluding to, but to put a nurse with somebody, you can do some things. You'll never cover all what you have today, but you can hit the core of what we see people are most needing. They've got to have medications. They've got to have some type of, outpatient therapy. A lot of that's going to be group. We've moved to this before in the system, and people, and a lot of times consumers don't like group. I get that. It's a huge cultural shift again. We've talked about it for years in this system, but just trying to look at how we might do that. What would a walk-in center really look like? And is there any way to leverage more of what we're doing in other parts of the system? So I just wanted to say that because it's one thing to look at the problem, but I've really been trying to be very solution focused as the rollout to the communication to the community and to the families, to the people this is really going to affect. So I just felt I need to say that, so thank you.
Now, there would be proponents of the financial strategy that's happening in Raleigh that we're struggling with, but there would be proponents of that strategy who would say to your remarks, see, it's working. Now, but there's got to be a balance somewhere. Now, maybe it's good that we see how far we can go, how much good we can do with the little bit we got. I think that would be some of those arguments. But where's the balance?
Yeah, and I totally appreciate your point.
And there's, and how do we find those efficiencies and still deliver what I would call a quality product. And limit, reduce, avoid as much harm as possible.
Absolutely.
There's just, the balance is hard to see.
I agree, and the quality, this is kind of this is my personal opinion. I've read a ton of research and articles and learned about models and visited models, and and people can even achieve the best outcomes in some of these alternatives we're talking about. But here in North Carolina, what I would say to the state I love and to all these people is that we won't know that for a while, what our outcomes would really look like, and how long it would take to do that. The other thing that I think is only fair, some of the providers have said, just like our staff read legislation and hear things and keep up with things, their staff are doing the same thing, and they're very concerned. So the workforce, you have a piece of the workforce now that's even more scared than it was 3 weeks ago. That's out there, and we know the turnover in this agency. So I'm not really trying to paint a doom and gloom picture, but what I've tried to do is just be very factual.
Well, in the short run, how many providers out there are literally going to drive?
It's hard to say.
Yeah, we have to wait and see what the decisions are.
Well, yeah, I mean, it's, think of a continuum, you have to draw on the wall, except that's not one where you can wipe it off, and probably get in trouble. There's money and there's services, okay? And there are some services that are expensive services, very valuable to people, and don't serve a high volume, right? And there are other services which are less expensive that serve a higher volume. So just consider where do you talk about the balance? That's the balance question. That's the balance. So how do you address the access, the number of people that can receive care, the intensity of that care along this continuum of utilization and expense? I'm just restating that's how we have already, sort of listed our criteria around that. And of course, it gets extremely complex as you start to dive down into this, because none of the things are. It isn't like we're not eating dessert, okay? No, this is a whole different. This is a whole different thing. So, I know we got a bunch of stuff at closed session.
All right. At this time, we'll go into closed session pursuant to North Carolina General Statute 143, 318, 11A1, in order to prevent disclosure of competitive healthcare information that is privileged or confidential pursuant to North Carolina General Statute 122C, 126.1, or not considered a public record within the meaning of Chapter 132 of General Statutes, and to consult with attorneys pursuant to North Carolina General Statute 143, 318, 11A3. Is there a motion?
I'll make a motion.
Second.
All in favor say aye. Aye.